Please, Ahmed. Sir, please start.
Thank you, sir. Good morning, everyone. I I'll speak about water drinking test and glaucoma. Water drinking test was first utilized around the 1920s as a method to diagnose glaucoma, but was later abandoned in the late 1970s due to its lack of specificity and sensibility. It has recently re-emerged as a possible way to determine the competency of the trabecular meshwork. IOP is a critical factor in glaucoma management, and dynamic assessments can provide valuable insights. However, it was associated with markedly unacceptable false positive and false negative results. Armali et al. Found a good correlation between IOP in the water drinking test and that in the 24-hour IOP curve. So it is now used as a useful tool to assess the IOP peaks. It has been speculated that water loading changes the plasma osmotic pressure gradient and causes an influx of water into the eye. Greenfield et al. Proposed that WDT raises IOP by increasing epicyclical venous pressure. Another proposed mechanism for IOP elevation is decreased aqueous outflow after WDT. WDT can cause parasympathetic nervous system stimulation, which may cause collapse of Schlemm's canal, leading to increased IOP. Water drinking test suppresses the trabecular meshwork by increasing epicyclical venous pressure, hence allowing the outflow facility and peak diurnal IOP to be evaluated. Furthermore, high IOP fluctuations have been implicated in glaucoma progression, most notably in the advanced glaucoma intervention study. Pre-test preparation includes patient education and baseline IOP measurement. The patient drinks a standardized amount of water within a specified time frame. IOP is monitored at regular intervals after water consumption. IOP measurements are recorded and analyzed. We ask the patient to refrain from drinking any fluids for at least 2 hours before the test to establish a baseline IOP measurement. Instruct the patient to sit comfortably in an examination chair. Measure and record the initial baseline IOP. This is typically done using a tonometer such as Goldman applanation tonometer. We provide a standardized amount of water, usually 800 ml to 1 liter, to the patient and instruct them to drink it within a specific time frame, usually 5 minutes. Monitor and record the IOP at regular intervals after the patient has finished drinking the water. This can be done at 5, 10, 15, and 30-minute intervals depending on the protocol being followed. Observe and document any significant changes in IOP in glaucoma patients. You may see variation in the IOP following the water intake. This is the IOP changes in various patients, POAG, control patients. This is a small video showing the excessive pressure in the trabeculum causing damage. Interpretation of results: normal IOP response, significant IOP increase, delayed IOP increase, IOP fluctuations with slow recovery, nocturnal hypotension, and exaggerated IOP response. Accuracy and consistency in test administration are crucial for obtaining meaningful results that can guide glaucoma diagnosis and treatment decisions. It's essential to adhere to established protocols and use appropriate equipment for IOP measurements during the test. This is the changes in the intraocular pressure from maximum to minimum and the end pressures. Various results. IOP has reached a peak of 35 also. We analyze the collected data to assess how the patient's IOP changed after drinking water, discuss the results with the patient and consider any necessary adjustments to their glaucoma management plan based on the IOP fluctuations observed during the treatment adjustments. Based on the results, consider any necessary adjustments to the patient's glaucoma management plan. This may involve changes in the medication or treatment timings. Follow-up, schedule any needed follow-up appointments or tests based on the water drinking test results. Accuracy and consistency in test administration are crucial for obtaining meaningful results that can guide glaucoma diagnosis and treatment decisions. It's essential to adhere to the established protocols and use appropriate equipment for IOP measurements during the test. Mention any specific instructions or precautions. Its clinical applications are like early glaucoma detection, individualized treatment planning, monitoring disease progression, identifying nocturnal hypertension, evaluating treatment efficacy, research and understanding, and personalized care. It provides a dynamic IOP assessment, identifies normal tension glaucoma, customizes treatment plans, addresses nocturnal IOP drops, monitors treatment efficacy, advances glaucoma research, offers patient-centered care, and enables early detection. There are various limitations and considerations like variability in results, patient compliance challenges, limited specificity, not a standalone diagnostic tool, standardization challenges, limited evidence in certain populations, resource intensive, diagnostic complexity, and ethical considerations. In conclusion, water drinking test is a valuable tool in glaucoma care, offering dynamic insights into IOP fluctuations. It enhances diagnosis, customized treatment, and contributes to research, but should be used alongside with other assessments and considerations. Thank you.
So the next speaker we have is Dr. Prasanna. Any questions on drinking water test for Dr. Rais Ahmed? We have enough time.
I want to ask,
Pointer.
sir, do you regularly do this test?
Ma'am, not regularly, but we are doing a study about it, and there are peaks. Well, we have
So in
observed.
POAG patients or PSCG
Ma'am, not
defined?
defined glaucoma patients. We may also do any suspected patients and see the peaks. Any patient having decreased visual fields or glaucoma progression despite IOP controls, they are the perfect candidates for this.
Because instead in our center we just make sure to tell them that
Don't drink
too
bolus
much
amount of water. Then there are at some centers hydrotherapy also going, like Ayurvedic hydrotherapy. They are giving 2 liters, 3 liters of water to the patient to treat some renal calculi or anything else. In such cases, this is a useful.
Thank you.
Other provocative tests, what are the tests you do?
This is a separate test we do. Other diagnostics like OCT and perimetry has to be
No,
kept
provocative
alongside.
tests like dark room test
Dark room test,
or
ma'am.
position, based on position prone.
No, ma'am. This study was alone, separate study. Water
Okay.
drinking only.
Fine. So next is Dr. Prasanna Venkatesh. He is already on the dais, decoding glaucoma module premium edition.
Thank
So his
you.
presentations are always more tech oriented, which is quite innovative at times,
you.
and we expect the same of this presentation
Thank
also.
Thank you, ma'am, for the kind introduction. So this is Glaucoma Module Premium Edition from Spectralis. I have no financial disclosure, but this is from shifting the Brooks membrane opening horizontal rim width that we traditionally used to do in our OCT to shifting BMO MRW, that is minimum rim width. I have no financial disclosure in Spectralis, but let us start with an animation here. So this is a sliced OCT of OCT optic nerve. You can see that there is a green line which is the internal limiting membrane, and this is a 3-dimensional slice of the same, and the red is the Brooks membrane. You can see that there is a red dot here. The red dot is a Brooks membrane opening, and usually we take the horizontal rim width, that is the distance from here to here. But now we are going to talk on Brooks membrane opening minimum rim width, that is the smallest distance between the internal limiting membrane and the Brooks membrane opening. So let us decode this Glaucoma Module Premium Edition, which is the new kid on the block for diagnosing OCT with glaucomatous patients. So I have used this template here. The blue is the RPE, the red is the Brooks membrane, choroid, and the green is the sclera, so that we can have this concept conveyed for neophytes in a much simpler way. So what is the true margin of the optic disc or the disc margin? So you can see that we tend to take the scleral ending, that is the green line. As you can see, I told the sclera is green. So we take this to be the disc margin that we see in a fundus photograph or in a direct ophthalmoscopy of fundus photographs. But in reality, in OCT, the definition changes where the termination of the Brooks membrane is taken as the disc margin, that is the red one, which is a OCT classification. As you can see, it is red. So now we are confused with two, whether it is the Brooks membrane ending or whether it is the scleral ending. So we can't have two, right? Because if you have two margins, one will be clinically assessed margin, which is, as you can see, which is marked as the green dotted line. Another one is the BMO based disc margin, that is the red dotted circle. So we will be ending up having BMO based disc margin and a clinically based disc margin. So we can't have two, right? Because there will be two areas, clinical disc area which is clinical and Brooks membrane opening area which is OCT based. So clinical disc area was larger than the BMO in BMO area in normal and glaucomata size. It was well proved. So you cannot have two swords in a single sheath. You can have only one. So this study by Chowan et al., which is cited the maximum you can see, was a path-breaking study which put to rest all the confusion. That is, the true margin of the disc is not the sclera ending, it is the Brooks membrane termination, because no blood vessels and axons can pass through the Brooks membrane. So then Brooks membrane will be taken as the structural boundary of the optic disc. So this, let us see what is again Brooks membrane opening. So we all know about this image, right? I'm just comparing it to the Niagara Falls. You have to have a three-dimensional perception of this image, how the RNFL comes and falls into the optic nerve end. Now this is what we see in reality. You can see the green internal limiting membrane followed up to the Brooks membrane opening, which is red line. Spectralis Glaucoma Module Premium Edition or GMP has 24 scan lines. You can see 24 scan lines. So it gives you 48 Brooks membrane opening positions. So what, again I'm just taking back you into this animation. The ILM is the green line, the red is the Brooks membrane, and the red dot here, I hope you are able to see the red dot, which is the termination of the Brooks membrane. So this is the red dot. I have kept my laser pointer there. So this is the Brooks membrane opening, that is a red dot. So you can see that in all 48 slices, for want of use we have 3 here, 3 here. So totally we have 12 slices. We can go up to 48 in your OCT camera, where you can see this red dot here, that is the Brooks membrane opening. Then what is Brooks membrane opening? Minimum rim width. So again I am taking you back into the basic sciences here. So we have the green internal limiting membrane, then the red Brooks membrane opening. So traditionally we used to take the horizontal distance between the green and the red. But now the concepts are changing regarding the minimum distance between the internal limiting membrane and the Brooks membrane opening. You can see the minimum distance. So that is called Brooks membrane opening minimum rim width. The green, the yellow part here, you can see that the yellow three-dimensional part here, that's called Brooks membrane opening minimum rim width, which is the smallest distance between Brooks membrane opening and the internal limiting membrane. So when you go for a decision, right, it will always be against something else. So why not Brooks membrane horizontal rim width? Because this is traditionally this is what we were doing, the horizontal rim width. Now we are changing to minimum rim width. So let us see some review of literature. Brooks membrane opening minimum rim width yielded a higher diagnostic performance than its traditional counterpart, the horizontal rim width. Also, the sensitivity of MRW was consistently higher than RNFL and Brooks membrane opening horizontal rim width. And you can also see the amount of neuroretinal rim tissue in glaucoma, if you see in this study, where a method to measure, it also was consistent with the MRW parameter. The mean deviation of visual fields, the visual field, that is the functional correlation, and the structural one that we are talking, right, the BMO MRW, they also correlated well compared to HRW. You can see that MRW, it correlated well. Again, the RNFL also correlated well. Innately, every one of us, just like our fingerprint, we end up having different optic discs. That, my dear friends, is the challenge in glaucoma diagnostics, because we may not be having the same disc. Each one of us may be having a different disc, and God has made us that way. So that is where the curse also lies, because of the variability. Many disc sizes is a curse, because the size or the area of the optic disc will influence the neuroretinal rim. So that is where the game-changing BMO MRW comes in, because see this example, a very practical one. Imagine a large disc and a small disc having the same area. So this patient and this patient, finally the neuroretinal rim area is the same. If you see the blue area, they both are the same. But a large disc will always have a small BMO MRW, whereas a small disc will always have a large BMO MRW. So this is the game-changing marker that OCT is giving us, because the influence of the disc size on BMO MRW is always there despite two areas being the same. So BMO area will always influence the diagnostic precision of BMO MRW, but not the RNFL which is passing into it. So these are some of the things which we need to know. One of the limitations in OCT that we need to keep in mind when we are actually evaluating a small rim thickness doesn't always mean that the RNFL is also damaged, because it works both ways depending upon the disc area. So again, always keep in mind, choose your RNFL if you see that the BMO area is very less, because as I showed you in this image, when the area is very less, as you can see in a small disc, that the BMO area maybe seem to be more larger. So at that time, you will always have to choose choose BMO MRW, and when the BMO area is more, you will have to choose RNFL. So these are simple tips and tricks that you need to keep in mind. And why GMP really hit very hard is, it's like a GPS. So I'll just show you an animation of how it works. So this is a single beam. You see this patient moving his eyes here. So whereas here if he is moving, you see since there is a dual beam in spectralis, it never loses track of the tissue. So every time, again see this on the this side, a single beam will lose focus on the section of the tissue that it wants to examine, whereas a dual beam, even if there is micro movement, it won't lose focus. It is like a GPS, same piece of tissue, even when there is a slight head tilt. Again, this is a real-time video of one of our patients where we took. You can see that with slight tilts also, the machine automatically aligns itself to examine the same piece of tissue, which we don't have with the traditional OCT machines. So that is another advantage. So every time, first it marks the center of the fovea, then it marks the center of the disc, or it is also called as Brooks membrane opening area. Then the fovea BMO axis is plotted, and then surrounding that you can see that the ganglion cell layers and RNFL is blocked. So the main crux point here is, even 1 to 2 micron meters difference, it will easily pick it up. In subsequent follow-ups where especially early glaucomatous damages, we can pick up even head tilts, cyclotorsions, even these we can easily help pick it up. I'm just winding up. So this impacts in diagnosing subtle glaucomatous changes very early. So this is one of my patients here where 2019 I thought the IOP is actually controlled. It was 15-16, but the patient tended to progress. You can see in 2020 and 2021 there was very subtle progression where I had to even put him on another medication and bring the IOP, which was 16 to 17, to even low teens like a 13 or 14. So this really helps in game-changing glaucoma. And most of my talk that I covered here about Brooks membrane opening, minimum rim width and horizontal rim width, it is there in my publication in IJO in April 2021 issue, as well as another publication in June 2022 issue in IJO videos. So thank you once again for giving me this opportunity. GMPE Spectralis is going to be the future glaucoma toolkit, where it is going to cut the disc in a 3-dimensional way, and it is going to make a mark in the structural evaluation and the way we are perceiving the structural orientation of glaucomatous damage. Thank you.
Your slides were quite interesting as always, Prasanna. Yeah, BMO that has been gaining importance since past about 6 to 7 years, I should say. There have been publications on it.
Yes, ma'am.
The way you showed that is spectralis and single beam, that is fascinating. There is not much question left. Actually, one comment I would like to make,
Yes,
that that ganglion cell complex, that is also something which we need to look upon. Even if it is early glaucoma, then sometimes GCC gets affected. So we advise 10-2 also these days, instead of just 24-2 as we have been doing in the past. Funny question just to loosen the house, I shall like to ask. You, in one of the slides, I noticed that curse of the disc, you have put Dr. Krishna in. So it is Mahalaya which is started, and I am a Bong, so maybe Durga Devi or something would have been better. I think Prerna has a question.
I have a theoretical question that even in the Cirrus Zeiss OCT, is BMO MRW only measured or BMO HRW?
Ma'am, in Zeiss, I am still thinking, in terms of BMO HRW, because this...
You do have that red spot present in
the red spot is there, the red spot is there, and even if you are there is always a manual measurement where you yourself can do the measurement of the minimum distance between the ILM and the BMO opening, the Brooks membrane opening, which will be the MRW. But the catch here with, I have no financial interest, but with Spectralis what happens is you measure the same piece of tissue in subsequent visits. So one practical point here I would want to make is a patient comes today in a traditional OCT where the head is like this, a slight tilt will change the whole way we are going to perceive the slices.
And
So
even
that
the foveal Brooks membrane opening axis is there in Spectralis. And
yeah. For BMO MRW is now coming up in all machines, but the APS technology, the anatomical positioning system, along with the BMO MRW, even with 1 or 2 micron distance, we are able to pick up, and early glaucoma it is progression, not damage. All of us will be picking early glaucoma and visual fields or OCD, but we think we have controlled the glaucomatous process, and the patient's IOP is 16 to 17 as one of my patients. Despite that, the patient was progressing, and that sign I was able to pick it up, and we may end up saving the patient's disability years. So that's what I wanted to highlight.
thank you.
Thank you, ma'am.
Any questions from the house, because we have enough time?
Sir, I titrate between OCT visual fields and fundus photographs, so it's like once in a year, sir. Yeah, I don't put them into a battery of investigations. Once in a year, I make sure I have at least one OCT, one fundus photo, and one visual fields.
Yeah, so me and Prerna, we are going through this because actually we don't have Dr. Nayak sir with us, Dr. Venkatesh or Dr. Veera Satyanarayana. So the next, Dr. Veera, sorry. So Dr. Veera sir is here. Veera V. Satyanarayana. I shall request you to take the dais, sir. And sir's talk is on ocular perfusion pressures in primary open angle glaucoma.
Good morning, I am Dr. Satyanarayana from Geeta Ministry of Medical Sciences, Visakhapatnam. Today my talk is on ocular perfusion pressures in primary open angle glaucoma. So far we know intraocular pressure is the only reliable modifiable risk factor. So far recent studies shows in spite of having a good intraocular pressure control, still the glaucoma is progressing. So now we have to on a path where you have to search for the other risk factors. And here I would like to suggest that intraocular perfusion pressures are the other major risk factors. So I have no financial interest. So primary open glaucoma is a subset of glaucoma defined by open angle, raised or normal intraocular pressure, leads to the RNFL decay, optic nerve changes and visual field changes. So sufficient blood flow is mandatory for the normal optic nerve head functions as per Harris study. And major arteries that supplies to the eye are the ophthalmic artery and central retinal artery to maintain its normal function. So etiology glaucoma is uncertain still despite of many experimental researches, but hemodynamic alterations contributes to the glaucoma. So disturbance in autoregulation, unstable ocular blood flow leading to chronic ischemia of the optociliary bed and deep retinal veins and layers, and is a risk factor for the development and also the progression of the glaucoma. So low perfusion pressure is a definite risk factor, optic nerve head function, and low ocular perfusion is a potential risk factor for the development progression of the glaucoma as per all these 4 studies conducted. And the measurement, now we have to measure the ocular perfusion pressures, like these are the methods available to measure, to record all the ocular perfusion pressures like ophthalmodynamimetry, color Doppler imaging, laser Doppler velocity scanning, laser ophthalmoscopy, ICG, and transcranial Doppler ultrasound. So what are the major readings we have to look at? That is the peak systolic velocity pressure and diastolic velocity, resistive index, pulsatile index, and blood flow velocity. And among these two, we have focused on the peak systolic velocity and resistive index in our study. So resistive index, that is gives the resistance from the blood vessel, whereas the peak velocity is the volume that is given by the blood flow. So trabecular meshwork also responds to the circadian rhythms. So that's why the intraocular pressure is unstable. unstable, even for hour to hour, day to day, week to week, even for years. So this trabecular measure that responds to the circadian rhythm. So our aim is to record the ophthalmic artery and central retinal perfusion pressures. We have done this study from the Geta Ministry of Medical Sciences in collaboration with the Radio Diagnosis Department. We included 20 patients of open angle glaucoma, 20 of controls. So we excluded the criteria of the uveitis, ocular conditions, ocular trauma, post-operative eyes, and systemic conditions like hypertension, diabetes mellitus, cardiac cases, chronic autoimmune diseases, and COPD and steroid. So this is the machine we have used, that is GE Logic S8 with the probe of 9HZ, and we mainly concentrated on the peak systolic volume and resistive index. And this is the study we have done by recording this ophthalmic artery perfusion pressures. Sorry. And this is the ophthalmic artery perfusion pressure, and this is the central retinal artery perfusion pressures we have recorded. So this is the flow. These are the readings of the ophthalmic artery perfusion pressures, peak systolic velocity, and we found that peak systolic velocity in ophthalmic artery is reduced in glaucoma, whereas resistive index is increased both in ophthalmic artery as well as the central retinal artery. So these are the index of peak systolic volume, CRA, and the systolic velocity is reduced and the resistive index is increased. So we did the same study in one patient where the one eye is normal, other eye is glaucomatous with advanced stage, and also found that this peak systolic velocity is reduced when compared to the normal, and the resistance index is increased and compared to the other eye, normal eye. In conclusion, we state that the peak systolic volume and resistance index are very important vascular parameters in the study of glaucoma, and peak systolic velocity is decreased whereas the resistive index is increased, and these can be included in the imaging diagnostic prognostic criteria for the open angle glaucoma. Thank you.
Yeah, thank you, Veera sir. So, ocular perfusion pressure, again, the more the technologies, more tests and investigations we have. I can only comment that the number of subjects which I noted, it was 20 in one of the studies, and then I think you did.
We initiated a small study.
Yeah, I think you did another study which you mentioned at the last, where you compared the same person, normal and high pressure.
Yeah.
So I think the number of subjects in that was a little more. You started doing the study, right? So that's a good study, of course. If we have all these technologies, then we can look into it.
Yeah,
but
wherever the facility of the radio imaging is available, we can refer these patients for these studies are definitely worth taking, and we find that the positive results which can be included in the diagnostic criteria as well as the prognostic also.
Right, sir. Yeah, prognosis also.
Right.
You're right about it. So, any questions, Dr. Prerna and the house? Okay, I think everybody has gone to trade area or breakfast maybe. So next we have Dr. Prerna Garg. She is speaking on Rho kinase inhibitors. Rho kinase inhibitors came just after the COVID wave, and they are being used abundantly now in certain cases and selective cases. To Prerna.
Yeah, so I'll be speaking about Rho kinase inhibitors. They were actually introduced in 2017-18. That is when they were FDA approved first. This is the basic mechanism. This is the trabecular meshwork, and these are the different layers of the trabecular meshwork. And as we can see, as it goes from inner to outer, the pore size decreases. So there's a funneling effect in the aqueous-humor outflow. Now, why this is important is because this is where the Rho kinase inhibitors act. There are no other anti-glaucoma medications which act at this area, and this is the main area which is damaged in an open-angle glaucoma or why IOP rises in primary open-angle glaucoma. So in this, we can see that the intertrabecular spaces are actually decreased in a POAG case. And the cytoskeleton has large number of filaments, microfilaments and microtubules, including actin and myosin filaments, which make this trabecular meshwork act like a muscle type cell and is responsible for the contractile function. So it was thought that let's find some agents which are acting at this area and causing the trabecular meshwork cell to relax and increasing the intertrabecular spaces so that the aqueous outflow resistance decreases and there's more aqueous humor outflow from the normal pathway. So initially what they found was microfilament disruptors like cytocalicins and latrinculins. So, but this caused a very non-physiological damage to the trabecular meshwork cells. It increased the spaces, but it was very non-physiological. Similarly, latrinculins. Then protein kinase inhibitors which uncoupled actin from myosin were discovered, but they also were a little bit more physiological but not reversible. So then Rho kinase inhibitor, the first agent to be discovered was Y27632, which was found to have reversible changes in the cell shape, and it primarily acted on two parts of the actin-myosin fibers, the stress fibers and the focal adhesions, and both of these acted to increase the intratrabecular spaces. And it was found that actually the outflow resistance decreased by as much as 65% in the studies. So Ripasudil first received its approval in Japan in 2014, and Etarsudil received in 2017. And both these agents, they received approval for ocular hypertension and POAG. And Roclatin, which is a combination of Nitarsudil and Latanoprost, has gained US FDA approval in 2019. So the mechanism of action is basically on the TM and the Schlemm cells where they increase the aqueous humor outflow. But because they have a vasodilatory action, they also are neuroprotective and increase the blood flow or the ocular blood flow. Also because the first agent which was discovered in Japan, Fasodil, is known to have effect on cardiac fibrosis and hepatic fibrosis patients. It has anti-fibrotic effect. So it was speculated that maybe these drugs also might decrease the fibrosis following a trabeculectomy. Nitarsudil was found to have two additional mechanisms, a norepinephrine transport inhibition, which would further lower the aqueous humor production and also decrease the episcleral venous pressure. It has been found, it was discovered to have other uses in ophthalmology, like in corneal endothelium, where it has been tried in fuchs and endothelial decompensation following cataract surgery, and other areas have also been tried. So it is being used as a first-line therapy, not very frequently, but these are the phase trials which were conducted. In the phase 1 trial, surprisingly, they found that in normotensive individuals, the latanoprost xalatin was given. It decreased the IOP by 3 millimeters mercury, whereas Nitarsudil decreased it by 6 millimeter mercury. So then they went ahead with the other trials, and the rocket trials were the phase 3 trials which were conducted, which included 4 trials. And they found that it had all the different mechanisms of action. It did not cause any aqueous humor IOP fluctuation during the day, so it acted equally during day as well as night. And what was surprising was that while timolol and latanoprost had higher IOP lowering at higher IOPs, like in the range group after 22 millimeter mercury, this acted equally throughout the IOP. So it also had a higher IOP lowering in normotensive individuals with low baseline IOP. And the dosing at night was preferred because the conjunctival hyperemia, which is known with these drugs, disappeared during the night. Similarly with Ripasudil, all the 4 trials had a similar effect and found that the IOP lowering was in the range of 3 to 4.5 millimeter mercury. And the most common side effect, again, which was noted, was conjunctival hyperemia. But in both all the studies it was found, it was mild, resolved within 2 to 3 hours. It has also been tried as an adjunctive therapy with good results. And there are a few cases in our center when we found that actually secondary open-angle glaucoma patients who were on maximal medical therapy, pressure was not controlled. When we started them on Nitarsudil, 0.02%, it actually became in single digits. So this patient was a 12-year-old boy, status was corneal tear repair and 270-degree angle recession. We didn't want him to undergo a TRAB. We just tried Nitarsudil. Pressure was not controlled on all the medical medications, including astazolamide. So, in 1 week when he came back for follow-up, IOP actually decreased, and it is like that. We have decreased the other anti-glaucoma medications and continued him on Nitarsudil, and pressure is controlled, and he has not needed any surgery till now. Similar other patients, out of which at least few patients, 1 or 2 patients did need a surgery eventually, but in lot it has been controlled with Nitarsudil in secondary open-angle glaucomas. So coming to the side effects, this was the efficacy which we found. Now conjunctival hyperemia has been very well reported. Other than that, in the rocket trials, cornea verticillata was reported in around 20% of the patients. Corneal or perilimbal microhemorrhages were reported. What we found in our center was the increased incidence of reticular corneal edema with this drug, especially when it was used as an adjunctive therapy when the patients are already on all the AGMs possible. And it was seen that most of the patients, all patients had compromised endothelium at the site of this reticular edema, and most of the patients had angle closure glaucoma, mostly secondary angle closure, but also primary angle closure. So we just felt that maybe in angle closure we need a more follow-up. It was a reversible side effect. As soon as we discontinued the drug, it resolved. Other side effects which have been reported in literature with these drugs include a punctal stenosis, anterior subcapsular cataract, also one case of nitarsodil-induced corneal flattening of around 6.5 diopters, which reversed on stopping nitarsodil. So these are reversible changes. The nitarsodil-related eyelid wound dehiscence has been reported, allergy as with other drugs. This is one case of antineurotic edema which we saw, which might be due to nitarsodil. So the indications include as a first-line therapy, as an adjunctive therapy. In normal tension glaucoma, it might have a role because it decreases the IOP more at low baseline IOP as compared to timolol and latanoprost, but it has not been studied. In secondary open-angle glaucoma and post-trabeculectomy to decrease the fibrosis. I feel that it is not recommended in corneal decompensation when the endothelial cell count is low, and maybe in angle closure it can be given, but requires a good follow-up. Thank you.
Yeah, Dr. Prerna, thanks for an interesting presentation. You covered almost all aspects of Rho kinase inhibitors. I shall like to ask some people, they say, or mainly the representatives, they say that if there is corneal edema post-cataract surgery, then these drugs can be used. So do you agree to this?
Yes, ma'am. Actually, I think it depends on the endothelial cell count and specular microscopy. So studies have not been done till that level right now. We think that we have started doing specular microscopy before prescribing Rho kinase inhibitors now to have a study like that. But maybe in even Fuchs and corneal decompensation, when there's early endothelial cell loss, not very severe, in those cases it might be helpful. Haven't seen any results as such, but might be helpful in those cases.
And corneal edema, that microcystic edema that is found only with nitarsodil, or it is also seen with ripasudil?
Both, mostly with nitarsodil, but nitarsodil is used with more higher frequency as compared to ripasudil. So in our case series, we have around 15-20. In those, 2 or 3 were with ripasudil, but it's not that it's only with nitarsodil. So there is some speculation that maybe ripasudil gets less absorbed and goes less in the anterior chamber, so there's less incidence. But we have found reticular corneal edema with ripasudil as well.
Right. So these are the third or fourth line drugs and indicated in NTG or non-responding cases maybe. They have not found great place in glaucoma armamentarium till date. But yeah, we hope to a better future. So any questions from the audience? Yeah, sir has a question.
Yes.
Nitarsodil, these Rho kinase inhibitors have multiple mechanisms of action.
Yes, sir.
Like they decrease the aqueous production, they have the outflow resistance also they decrease, or they have a neuroprotection. Still the IOP lowering is 3 to 4 mm only.
So they also decrease the episcleral venous pressure, and that's why we found that sometimes with nitarsodil the IOP actually becomes in single digits. So with no other agent we can see the IOP to fall below 8 or 10 millimeter mercury. But with nitarsodil we have found.
Recommended as first line therapy.
Not really, but the rocket trials recommended it as first line, but we are not using it as first line. Maybe we need studies for that.
Generally the first line drugs, especially the latanoprost or timolol, they decrease at least 1/3 of the IOP.
Yes. So the IOP lowering which they found in the studies was around 20 to 25%. So that is actually quite comparable to beta blockers, but we have not been using it.
The recommendation is not that
No.
they cannot be used as a primary
No.
single line therapy.
No, I don't think even in the European guidelines it's recommended as first line right now.
Thank you.
Thank you.
Yeah, so I think that's all from the house. So next I think I invite myself for the talk, Dr. Lipi Chakrabarti. I think it's already put up. So it is on save the failing bleb release pressure of eye surgeon in patient. What happens is that when a glaucoma surgery fails, then सबका pressure बढ़ जाता है, वो आँख का हो या फिर patient का हो या फिर surgeon का हो. So I'm here to release some of this pressure by trying to manage a failing, not a failed, but a failing trabeculectomy. No financial disclosures here. So first, what steps we need to do when we try to manage a failing trabeculectomy, a failing bleb? Recognize failure. We should know what are the signs of a failing bleb. Next is to identify the probable cause or causes. Treatment part involves dealing with the increased intraocular pressure and trying to restore the bleb function. So we'll be coming to this one by one. This is the famous classification. Can I have it from the audience? What is this classification if you're into glaucoma? This is the Indiana bleb, as Prerna told. So this is the Indiana bleb classification. We should have an idea that how a low-lying bleb that looks, how a high bleb looks, what is avascular cystic, what is mild vascularity. The pics, maybe they are not so clear on the screen, but you can find this image almost everywhere. In a glaucoma clinic, we have this. So having a cataract surgery, I often quote, it is something like having an affair. You know, whether you are doing a day affair or a night affair, it depends on that. So you forget about it. You have it and you forget about it. But getting a glaucoma surgery done or doing a glaucoma surgery, doing a trab, it is something like getting into marriage. So you have to stay with the eye, with the patient, almost lifelong. So the first step in management of failing trabeculectomy is recognize failure, elevated IOP with a deep anterior chamber. I'm not coming to the causes of elevated IOP with shallow anterior chamber. There we have aqueous misdirection syndrome and other causes. So elevated IOP with a deep anterior chamber. Here we have the typical failing bleb, which is low to flat, heavily vascularized, no microcyst. Causes may be tight sutures, internal block due to iris blocking the ostia or vitreous, incomplete excision, not a good punching. The next variety we have is the encapsulated bleb, commonly known as tenonsis. This is highly elevated, a very different appearance as we can see here. From the previous one, it is a smooth domed, large vessels, but intervening avascular spaces will be there, and there has to be a patent sclerostomy in case of an encapsulated bleb. Next step is identify the probable causes. So if it is an internal block, it is due to iris, ciliary body, vitreous or fibrin which is blocking the ostia. If it is an external block, then it is episcleral fibrosis or it is encapsulated bleb, as we just saw the differences. Encapsulated bleb that occurs about 1 month or 2 months of surgery, and that resolves at times with topical AGMs. So the causes, internal or external block, black rays, it is more common in certain countries, in certain races. Inflammatory glaucoma, post-traumatic secondary glaucomas, history of previous surgeries, it is trabeculectomy or cataract surgery, history of bleb failure in the same eye or the other eye, young age and males because there is more fibrosis, so they are more prone to failure. Now coming to the treatment. Treatment involves a wide modalities, a wide spectrum of modalities like bleb massage, anti-inflammatory therapy, steroids, AGMs, removal of releasable suture, LSL, bleb needling, bleb revision, and there are some miscellaneous procedures. Digital bleb massage. Now this is something which we start early on, even 3rd or 4th day we can start. Gently we have to do from the upper lid. It has to be guarded on slit lamp or under proper supervision. This breaks early adhesions, forces aqueous through the patent sclerostomy. Intermittent, they should be intermittent and can be taught to the patient. When this is taught to the patient, it should be done from the lower lid for the patient. घर में करना है तो नीचे वाले lid से करो, ऊपर से क्या कर ज़्यादा pressure पड़ जाएगा, so AC can collapse. Anti-inflammatory therapy, that is in the form of steroids, AGMs, whatever is suitable. Topical aqueous suppressants are preferred. Avoid this inflammatory drugs, might cause inflammation, PGAs, prostaglandin analogs, primidone that causes more of allergy. Topical anti-glaucoma treatment used particularly for encapsulated blebs. That's a tenonsis which we saw some time back. Removal of releasable sutures. So this releasable sutures, these are applied many a time by comprehensive and glaucomatologists. This removal can be done even 2 weeks, 3 weeks. After 2-3 months, this does not result in much of a result because fibrosis sets in. One suture is to be removed at a time and apical suture has to go last. So here a nice bleb is formed without any digital massage, just the apical releasable suture is removed and we can get a nice almost overhanging bleb. Always check the AC depth after doing all this digital massage and removal of sutures. So here is a patent PI, that is laser, iridectomy, surgical iridectomy done during trap, and we are getting a good Van Herrick. Laser suture lysis, again there are different settings and DIAG is mostly used. One suture at a time has to go within 3 to 6 weeks. This is to be done better, and always digital massage should be given after lysing one suture. If we are finding that the bleb is not forming, digital massage dene ka. So this is one case, 3 intermittent sutures have been used. This is one of the early cases of fellowship. Here what has not been done, digital massage. sutures तीनों lice कर दिए गए हैं, all 3 sutures have been lice, but distal massage has not been given. So now distal massage is being given. It is being given gently, intermittent, and we can see that the bleb has started forming. So I have not edited this. I have kept the same speed. Yeah, so we can see that a nice bleb is forming here. See how it is rising, and this goes to, yeah, so with a little distal massage, look how nicely the bleb has formed, and again we are checking the Van Herrick. Bleb needling, this is associated with subconjunctival injection of MMC or 5FU. We go with a blunt needle, whatever one is comfortable with, 23, 24 gauge, and then we blindly, this is a blind procedure as such, we remove that fibrosis, and that needle, if it goes through the ostia, then it is even better. Ostia se jo humko leke jaane ka, and we have to see whether the sclerostomy is patent or not. Sometimes this is done with anterior chamber maintainer also to see the direction of fluid into the bleb. Bleb revision, if nothing works, then dissect conjunctiva from fibrous tissue, excise the fibrous tissue, resuture the conjunctiva, and plan for a second glaucoma surgery. Miscellaneous tissue plasminogen activator that may be injected subconjunctivally when blood or fibrin present in aqueous outflow pathway. This is more of a theoretical thing. NDR laser disruption, yes, it is done if something is blocking the ostia, if it is fibrin or it is a iris which has not been cut nicely, then we can do NDR laser disruption of that. So to conclude, for management of failing trabeculectomy, we should first need to identify that the bleb is failing. Evaluation of probable causative factors, we need to discuss the situation with patient and relatives, address the cause if we can, and if nothing works, then as I told, it's like a marriage. Ultimately, you have to divorce it and then plan a second marriage, plan a second surgery. That may be the newer procedures or valve or even a second trap. So what seems to be an iceberg when we think of glaucoma surgeries is actually only the tip of the iceberg. There are many underlying factors, underlying causes which we need to consider when we evaluate a case of post glaucoma surgery. Thank you. Yeah, I think Dr. Prerna has some question. This mic is off. The battery is gone. I think you can use this if you want to.
Thank you, Dr. Lippi. That was a really nice presentation.
Thank you.
Ma'am, I just want to ask that in the early, suppose within 1 month of trabeculectomy, if the bleb is failing, if there's impending tortuous vessels, so would you take the patient up for bleb needling in the OT or a 5FU would you give, other than bleb massage, and you've done all that? It's a traumatic glaucoma case maybe.
Okay, so if that is, as madam is telling, it is a case which we expect already not very good results, like it is a post-trauma glaucoma or secondary glaucoma, pressures have been too high, and the surgeon has done good punching and everything, and releasable sutures or lies the sutures, done digital massage, and then if the bleb is not working, yes, I might take the patient for bleb needling. I don't do it on slit lamp as some surgeons do. I properly have to counsel the patient and take the patient to OT. Though I don't.
What about 5FU injection in the OPD, the 5 doses which we can give inferiorly?
Yeah, so I have been actually into Arvind. Their 5FU, still it is not used that much, and at that time also it was not used. So I'm more of a MMC person. But yeah, 5FU injections, I think they give it in North, and
it
can be
frequently in secondary glaucomas when we feel that there's impending failure.
Yeah, so yeah, you can say tell the dose and all for the benefit of the audience. We give it weekly, I think, in OPD.
Every day.
Every day.
Obviously, if it's difficult to call the patient every day, then we call them on alternate days. So it's a total dose of 25 mg and 0.5 ml. It's like 5 mg and 0.1 ml is one dose, first dose, and then call the patient ideally every day and give it for 5 days. So it's 25 mg total. But and we give it 180 degrees away from the bleb, so blebs are normally superior. So and in the inferior fornix, avoiding the conjunctival vessel and avoiding any, the drug should not come out into the conjunctiva. There should be a proper bleb formed with the 26 gauge needle. So we give it not very frequently, but if we feel that there's an impending failure, we do give a trial of 5FU first. And it does work in a lot of cases.
Right. Thank you for the insight, Dr. Prerna.
Any other questions which anyone has?
I think there are more speakers.
So there's Dr. Vaibhav Kumar Jain. Yes, sir. So, sir will be talking about on early phacoemulsification and acute primary angle closure, the efficacy and the challenges.
Good morning to all of you. Today my topic is early phacoemulsification in acute primary angle closure, their efficacy and challenges. So coming to the introduction, India is having significant number of patients with primary angle closure glaucoma, which almost forms the half of the adult primary glaucoma in various studies. So acute angle closure is relatively rare as compared to chronic PACG or subacute primary angle closure. But it poses an ocular emergency because it is accompanied by sudden rise of intraocular pressure and patient experience severe headache, nausea, vomiting, redness and watering. So laser peripheral iodotomy is the current standard treatment of these patients because it breaks the attack. But laser peripheral iodotomy is relatively it's not without any adverse effect. It is relatively difficult to perform if the patient present with the acute primary angle closure attack. Because of thickened iris, we need to deliver more energy with the Nd:YAG laser. Pupil is also mid-dilated. It can unable to get the pilocarpinize that pupil. Lot of inflammation may be there in these eyes, and lot of pigment shedding occurs during doing the peripheral iodotomy. And also greater endothelial cell loss occurs because of the shallower anterior chamber or almost flat anterior chamber. Also cataract development enhanced by doing these laser peripheral iodotomy in these patients. There is another option of surgical PI in these patients. So if you are unable to perform the laser PI, we can consider doing surgical PI, but it is relatively less preferred due to the invasiveness of procedure. So in one study, the surgical PI was associated with more surgical re-intervention as compared to phacoemulsification in these patients. Now coming to EAGLE trial, that is a multi-center RCT, and it is done in the 5 countries and 419 participants. So they showed that the clear lens extraction was more efficacious and cost effective as compared to standard LPI. And there were further reduced need of further glaucoma surgery in clear lens extraction group. Also there was reduced need of anti-glaucoma medication in clear lens extraction group. So there are certain RCTs which compared the phaco versus laser peripheral iodotomy in acute PAC. There is relatively less RCT, only 4 I have found. So they showed that the phaco is having better IOP control and fewer anti-glaucoma medication needed for post-op. Also after doing phaco, the anterior chamber is deep and also it improves the visual acuity. Now coming to effect of phacoemulsification on IOP, there is a report of American Academy of Ophthalmology, and there is 71% reduction from the presenting IOP after doing phacoemulsification in these procedures. And these patients rarely require long-term medication to control the intraocular pressure. Now how safe is lens extraction in acute PAC? So there are certain challenges in doing phacoemulsification in these patients. Like capsular access is a relatively difficult part because you don't have a space. You have shallow to almost flat AC. So you need to do the proper AC reformation before attempting the capsular access. Chances of Descemet membrane detachment is also there. These pupils are not able to dilate properly, and we have to control the intraocular pressure by giving pre-op mannitol, and medical control of IOP is must before. Chances of PCR is also high in these patients. So there are certain fewer surgical trips to avoid the complication. First of all, surgical expertise in phaco is needed before attempting these cases in acute PAC. Ample use of high density viscosurgical devices are must, and use of pre-op mannitol is also must. And a good hydrodelineation is also must, because these cataracts are mostly grade 1 to 2 nuclear sclerosis. They come with the just hydrodelineation, and we can take it out with the phacoemulsification. Now we have done a study in our center. So we have recruited till now 14 patients of acute PAC. This was a prospective non-comparative interventional series. So we we took patients of 40 years or more and presented with acute primary angle closure of typical clinical symptoms. The angles were occludable and the outcome measures were best corrected visual acuity IOP, number of quadrant in which we are able to see the PTM on gonioscopy, and the number of AGM. The follow-up was relatively short. So this was the baseline data. We can see the pre-op IOP was 38 millimeter mercury. In these patients, lens thickness was also high, around 4.9 millimeter. And none of mostly occludable angles, so only 0.13 mean value is the number of quadrant in which the PTM was visible. So we can see the IOP trend after surgery. Dramatically, IOP has come down after phacoemulsification, and mostly I have experienced the patients are without any anti-glaucoma medication after surgery. And also the number of anti-glaucoma medication, mean number was 4.2 and has come down to 4.4. And BCVA has significantly improved after surgery. So these are the literature which have mostly few studies are here in the literature. And we noticed one Descemet membrane detachment in one patient that was resolved with the further intracranial air bubble injection. No other significant complication was noticed. So lens extraction in acute PAC is a challenging task. The surgery should be performed under the pre-operative mannitol before the dilatation of pupil, and phacoemulsification should be performed using high density viscoelastic material like sodium hyaluronate, which reduces the chances of capsulorhexis runaway. We report the significant improvement of BCVA, well controlled IOP, and reduction in the number of AGM and number of quadrant in which PTM was visible on the gonioscopy. So coming to conclusion, the early phacoemulsification appear as an effective option for medically controlled acute angle closure attack associated with cataracts, grade 1 to 2 cataract. Thank you so much.
Thank you, sir. So this is in the study, can I just clarify, this is without a laser PI when the patient is coming?
Yeah, without laser PI we have performed straight away phacoemulsification in these patients.
The patient
And I have
one day control the pressure, and after how many days cataracts are
within a week.
Within a week.
We have admitted the patient, and patient was on mannitol or everything, glycerol.
Steroid also?
Not steroid. So we have found the significantly pressure has dramatically come down to 14, 15 without any anti-glaucoma medication from first post-op. So we are, yes sir, glycerol. Yeah. Yes, sir, glycerol was also given, and before surgery, the routine pre-operative mannitol was given in these patients. We are recruiting more patients in this study, so we are trying to publish it in some good journal. Sir, within a week. Mannitol 300 ml, sir. In 20 minutes, yeah. Yes, 20 minutes.
So the mannitol is given even when the patients come with the attack, and then once before surgery?
Yeah.
Like, is the pressure measured again before surgery?
Before surgery, we generally measure the pressure. It must come down below 30 millimeter of mercury. So before surgery also we measure the pressure, but next post-op day, in all cases we get the good result. No sir, till now not, but we experience the difficulty of doing phacoemulsification in normal routine cases versus acute attack. It was relatively difficult to do.
Actually, these patients have angle closure attack secondary to a high lens vault.
Yes.
That's why. So then there's some difficulty in the CCC.
Yeah, CCC was difficult, and also there are
It can run out.
risk of runaway is very high in these patients. But results, because we also experience the difficulty in laser PI also. Sometimes we don't get lot of pigment shedding, then patient will develop cataract after 3 months or 4 months. Sir, earlier we used to do laser PI in these patients earlier, but right now we are just doing the phacoemulsification in these patients. Thank you.
Thank you. Thank you.
Thank you. Ma'am, Yeah, surgical tip, we can use the AC maintainer, though we have not used it. But we can, for deep anterior chamber, we can use the AC maintainer also.
Might make manipulation easier.
Yeah,
Thank you, sir.
thank you. Thank you,
So we
audience.
have a last presentation by Dr. Chalapati Reddy. He's there. So he will be speaking on IOP monitoring preoperatively and postoperatively. Their experience in their center. Yes. I think it's
be not that relevant to this present gathering, but still I want to make it a point that we have done our IOP monitoring short-term study at PSR Government Regional Eye Hospital, Kurnool, and this is about IOP monitoring pre-operatively and post-operatively. And our observations are like inflammation. Sorry, I have pointer. Inflammation is a natural response to tissue damage after cataract surgery, and which can be damaging to the ocular environment. And one such thing is steroids can control this, inhibit the production of leukotrienes and prostaglandins, so thus decreasing the inflammation, and it might improve the visual outcomes. But steroids have significant side effects also. One such one is raised intraocular pressure. In our study, our corticosteroid-induced increase in intraocular pressure was seen in most of the patients, and other risk factors for raised IOP are pseudoexfoliation, vitreous or residual cortex in the anterior chamber, and retained viscoelastic materials, and pre-existing glaucomas and advanced age, diabetes are some of the other causes. The persistent elevation of IOP can lead to optic nerve damage, and here in our study we have done we have seen patients from 15 to 80 years of age group, and all of these patients either underwent uneventful small incision cataract surgery or phacoemulsification. And exclusion criteria was pre-existing glaucomas and previous comorbidities like iridocyclitis and paraoperative complications like PCR or vitreous disturbance, remnant cortex or zonal dehiscence, etc. And patients already on corticosteroid for either systemic or topical use we have excluded, and other connective tissue disorders also we have excluded in the study. And our aim of this study is to evaluate IOP fluctuations following cataract surgery with topical corticosteroids. Here, this is an observational cross-section study where we have selected 200 patients coming to our cataract OPD at Regional Eye Hospital, Kurnool Medical College, and all the patients were recorded, IOP was recorded by non-contact tonometry for better compliance, and compared with the first post-op day, and at the end of first week, and at the end of second week, and at the end of fourth week and sixth week post-operatively. Patients were given topical eye drops in weekly tapering doses with a fixed combination, that is gatifloxacin and dexamethasone sodium phosphate, 0.1% dexamethasone, which is applied at to our patients free at REH. And high-risk patients like patients with diabetes mellitus and other complications, we have included NSAIDs, and patients with dry eyes, we have included, we have added lubricants, and these NSAIDs were started at the end of second week post-operate. The following parameters were assessed and significantly, and their significance verified by statistical means, and fluctuation IOP from baseline we have taken into consideration, and difference in recorded IOP at different time period we have taken. Age and sex was also considered, and steroid response will be graded according to the rise in IOP from the baseline. That is as done by Armel et al. Here the low fluctuation we call it when the rise in baseline IOP, rise in IOP is less than 6 millimeters from the baseline, we call it low fluctuation. And if there is between 6 to 15 millimeters of rise in IOP from baseline, we call it medium fluctuation, and if the fluctuation is more than 15 millimeters, we call it high fluctuation. And the results in our study are, in our study we observed steroid-induced IOP elevation following topical steroids after 4 weeks post-op. The prevalence of steroid responders in our study was 9%, which is really high, as we are doing highest number of cataract surgeries in the world. And mild rise in IOP was seen in about 5.5% of these patients. And moderate rise is seen in 3.5% of the patients. That is 11 patients out of 60 of the patients we have seen, and 7 patients in these 300 patients, 5.5% had a mild rise, and about 3.5% there is a moderate rise, and none of the patients had a severe rise in IOP. The highest mean IOP was noted at the end of 4th week follow-up. That is, the mean IOP was about 23.5, where the baseline IOP was 15.5. The second highest mean was seen at the end of 1st week. Probably it could be inflammatory reaction. And the males were about 120, 112, and females were 88. And this is the age distribution between 50 and 18. And mean age was about 65.1. And this is the one. The preoperative mean IOP in our series was 15.25. And first postoperative day, there is a dip in the intraocular pressure by 1 millimeter in the mean. And at the end of 1st week, there is a rise by 5.98 millimeters from the basal mean IOP. And at the end of 2nd week, again it has plateaued back to 0.89 increase. And at the end of 4th week, there is an increase of 8.27 mean IOP from the baseline. And at the end of 6th week, it has come down to again 1.98. That itself shows that, see, in this graph you can see first day there is a dip in the intraocular pressure, but at the end of 1st week there is a rise in the intraocular pressure, probably because of inflammatory factors also. And then again in 2nd week the pressures have come down to near normal, and then but the end of 4th week the pressures have shooted up. And when we have tapered the medications, by 6th week the pressures have come down, but not to the bottom baseline. In our study of 200 patients, they're ranging between 50 and 80 years. We have seen that there is no sex or age-related spike in intraocular pressure. It was evenly distributed among all the groups, and which Kusne et al., who have done about on 3,488 patients, also found the similar results. And there was other study by Han Dong on 222 patients, where he has used becifloxacin with prednisolone acetate compared with becifloxacin with NSAIDs, and there was no for 14 days, and there was no significant difference between the postoperative inflammation. And the study demonstrated that topical steroids are equally efficacious when compared to topical steroids alone, and ophthalmology should consider using 2-drug regimen in managing postoperative cataract complications. And the paradigm shift in pharmacotherapy post-uncomplicated cataract surgery has deviated little from the norms as indicated by American Academy of Ophthalmology preferred practice patterns. Based on this current study and others, the authors believe that the pharmacological approach should be tailored to each patient and should not have a similar regimen for every patient, and a standardization of treatment for all patients. Tailoring will increase the compliance, and fewer drugs is always better. But then again, we have to monitor the intraocular pressures before continuing the medication. In our study, 18 subjects, that is about 25, having more than 25% raise in IOP from the baseline, itself speaks the volumes of steroid responders among our post-cataract, uneventful post-cataract surgeries. That's about 9% among study. And 11% has a mild rise, that is up to 6 millimeters increase from the baseline, and 7 subjects, that is about 3.5%, had a moderate rise, that is between 6 to 15 millimeters increase. So I conclude by saying the shortcomings are our sample size is small. 1 minute, no? Sample size is small, and we have not compared between SACS and phaco emulsification, and all surgeries were done by either by senior faculty, postgraduates, and trainees also, and so the inflammatory process may be different in different cases, and we have not compared it with other steroid regimens. And conclusion, the small study highlights the need for IOP evaluation at every post-op follow-up, and need for alternate safe post-operative treatment regimens is the need of the hour. Thank you.
Thank you, sir. So we are already running short of time, so.
I know the other team is waiting.
Yeah.